Thank you for the very generous introduction, Dr. Chow. Um, I'm going to be talking about ARVC, reviewing some of the guidelines, and doing a clinical overview. To just go over some learning objectives, first we'll review the definition, pathogenesis, and clinical spectrum of ARVC, providing the foundation for understanding the disease. Second, we'll apply and interpret the evolving diagnostic criteria. And finally, we'll evaluate the evidence-based management strategies and highlighting the current gaps in the literature to guide clinical decision making, as well as kind of the changes in diagnostic criteria over the years. So ARVC is an inherited cardiomyopathy characterized by progressive fibrofatty replacement of RV myocardium, which predisposes patients to ventricular arrhythmias and structural remodeling. The condition was originally termed ARVD, which was arrhythmogenic right ventricular dysplasia, but the terminology has really evolved over the years and is most recently characterized as arrhythmogenic cardiomyopathy to really reflect the broader spectrum, including right dominant, biventricular, and left dominant phenotypes. It is fundamentally a structural myocardial disease defined by RV functional and morphologic abnormalities and/or histopathologic evidence of fibrofatty myocardial infiltration. And ARVC typically manifests in young adults, most often between the second and fourth decades, as it is recognized cause of exercise-related sudden cardiac death, especially in athletes. It is the second most common cause of sudden cardiac death, especially in young people after hypertrophic cardiomyopathy. ARVC often presents with VT of RV origin, classically as monomorphic VT with left bundle morphology. This pattern reflects delayed electrical activation through diseased RV myocardium. Anatomically, the disease is characterized by regional wall motion abnormalities, myocardial thinning, RV dilatation, and fibrofatty infiltration. One of the things that's often mentioned in the literature is for the pathological substrate is that it typically involves something called the triangle of dysplasia. So this usually involves the RV inflow tract, the outflow tract, and the RV apex. As the disease progresses, there can be global RV dilatation, and in some patients, LV involvement develops, reflecting a biventricular phenotype. Contemporary classification, as I'll get to more later, now recognizes kind of this heterogeneity of the ARVC spectrum, emphasizing its genetic, structural, and phenotypic variability. So this is a case report that I came across that I felt really highlighted well the course of ARVC over time, and I think it would be a helpful exercise to go through a case in real time, especially since they follow the patient over 15 years throughout the multiple stages of the disease. So this is a 52-year-old male who was admitted because of monomorphic VT, which required cardioversion. He was hospitalized and evaluated at that time. His past medical history included hypertension, diabetes, CKD, and bronchial asthma. He had no family history of specific cardiovascular disease. On physical exam, he had a normal JVP, no leg edema, and no cardiac murmur, all to say that he didn't show signs of heart failure. And the chest X-ray showed a cardiothoracic ratio of 49% with no signs of pulmonary edema. During normal sinus rhythm, the ECG had showed epsilon waves, which I'll show some more ECGs later and more detail on epsilon waves, but showed epsilon waves on V1 and V2, which is a classic depolarization abnormality associated with ARVC. And echocardiography revealed a dilated RV, but LV size and systolic function were preserved, indicating an isolated RV involvement at this stage. Cardiac cath showed normal pressures in all chambers, and there was no evidence of CAD, which helped exclude ischemic disease as a cause. And endomyocardial biopsy was done actually multiple times in this case, but the first one showed mild fibrosis and disarray of myocardial fibers, supporting the diagnosis histologically. Based on these findings, the patient was diagnosed with ARVC and underwent catheter ablation for VT. This figure shows the VT morphologies recorded throughout the patient's clinical course. So panel A represents the first VT documented at the time of diagnosis. Panel B through E shows 4 different VT morphologies that developed during follow-up. Panel D and E demonstrate VT with an inferior axis. All this to say that this illustrates progressive electrical heterogeneity in ARVC with multiple VT circuits emerging over time, which is typical as the disease substrate evolves. About 14 years after the initial diagnosis, the patient began to show progressive signs of right heart failure with leg edema and ascites. He also developed atrial flutter, which was successfully converted to sinus rhythm with cardioversion. And despite optimization of medical therapy, his right heart failure continued to progress over time. He represented to hospital with palpitations and chest discomfort, and ECG demonstrated sustained monomorphic VT, again requiring cardioversion to restore ultimately to sinus rhythm. During that same hospitalization, he experienced VT again through with a different morphology, and again, really just highlighting the progression and arrhythmic variability over time. The ECG at this stage revealed loss of QRS voltages and prolongation of the QRS interval compared to prior study, again reflecting disease progression. His echo, compared to previous now, demonstrated marked RV dilatation. His LVEF is now reduced, whereas previously normal to now to 33%, with abnormal septal motion, indicating biventricular involvement. Cardiac cath showed elevated RAP without significant pulmonary artery hypertension, and right ventriculography revealed a marked enlarged RV with mild TR and diffuse hypokinesia, confirming advanced structural disease. EMB from the RV apex showed marked myocyte loss with fibrofatty degeneration consistent with ARVC and progression of that compared to the previous EMB. And an EP study induced two sustained monomorphic VTs with different morphologies, again reflecting the different arrhythmic substrates. Amiodarone was increased to 300 milligrams daily at that point, and an ICD was implanted for secondary prevention. And of course, this took many years to get there. And over follow-up, multiple VT episodes occurred that were successfully treated with ATP. The patient required high-dose diuretics, recurrent paracenteses, all in keeping with right heart failure, and just highlighting the end-stage progression of this disease. This figure shows the ECG and echocardiographic findings at the time of diagnosis and at 15 years of follow-up. And panel A shows the initial ECG obtained after cardioversion, demonstrating normal sinus rhythm with a right bundle branch block pattern. An epsilon wave is indicated there, you can see by the black arrow. Panel B shows the ECG obtained 15 years after the diagnosis. There is a loss of QRS voltages in the precordial leads and prolongation of the QRS duration, reflecting disease progression. And panel C shows the initial echocardiogram demonstrating dilated RV with preserved LV function with an EF of 50%. And panel D shows the echo obtained 15 years after the diagnosis, where RV is further dilated and EF is further reduced now at 33%, representing biventricular involvement. So the stages, ARVC typically progresses through 3 to 4 recognizable stages, reflecting both electrical and structural evolution. The names of these stages really vary quite widely in the literature, so I think a lot of it is at times semantics, but it does help to kind of wrap your head around of how the disease progresses. So generally, the first stage is called the concealed phase. Patients are usually asymptomatic at this point. Structural abnormalities may be minimal or absent, and despite this, they remain at risk of sudden cardiac death, often as the first manifestation. And diagnosis in this phase is really challenging due to the lack of clinical features that are not yet diagnostic. The second stage is the clinically overt or overt arrhythmia phase. At this point, patients develop symptomatic VT and show ECG changes such as epsilon waves or T wave inversions, not always, but in generally speaking. And many patients meet diagnostic criteria during this stage, often after presenting with VT or other arrhythmias. The third stage is overt contractile impairment phase. This involves progressive RV disease and in many cases LV involvement beginning to appear. Structural abnormalities become more prominent on imaging and patients may start to develop signs and symptoms of heart failure. And the final or end stage represents advanced disease with severe RV and/or LV impairment. This corresponds clinically to right, left, or biventricular heart failure. About half of patients with ARVC eventually will progress to this stage. But ultimately, these stages really reflect a continuum of ARVC, and they're not really discrete steps. The patient can present at any point depending on their genetic background, activity level, and disease progression, and sudden cardiac death can occur in any phase. This image is from the case report that I discussed, which really depicts these stages well with a real example. And you can see here over a 15-year follow-up, the patient's clinical course reflects the typical phases of ARVC progression. Initially presented with VT, but had no overt heart failure symptoms, consistent with the concealed phase where electrical abnormalities predominate despite minimal structural disease. Over time, he transitioned into the clinically overt phase, characterized by progressive RV structural changes and the emergence of heart failure signs, including leg edema, ascites, elevated JVP, and an increased cardiothoracic ratio. And ultimately, this represents progression towards the right heart failure phase, where structural and functional RV impairment becomes clinically evident, and then EMB, ECG, and echoes were used throughout follow-up to monitor this evolution. This slide outlines the three phenotypic variants of ARVC within the broader kind of now classified arrhythmogenic cardiomyopathy spectrum. So the dominant right variant represents the classical phenotype. The disease predominantly involves the RV, leading to RV dilatation, regional wall motion abnormalities, and VT with left bundle morphology. In this form, the LV remains structurally and electrically normal. The biventricular variant involves, as you can probably tell, both ventricles. Patients show structural, electrical, and tissue abnormalities in both chambers, and LV involvement often includes reduced LVEF and late gadolinium enhancement on cardiac MRI, and VT can arise from either ventricle. The dominant left variant is by definition without RV abnormalities, and cardiac findings can include subepicardial or mid-myocardial LGE on CMR and T-wave inversions in the inferolateral leads. VT usually shows a right bundle morphology reflecting a left arrhythmogenic substrate. This slide here, I just wanted to touch on kind of how the diagnostic criteria has evolved over time and has actually evolved further beyond this table, which I will very briefly touch on. In 1994, the diagnostic criteria was the task force criteria, were the first standardized framework for diagnosing ARVC. They focused on RV structural, histological, ECG, arrhythmic, and familial features. These criteria had a high specificity, meaning it was reliable to get a diagnosis, but they lacked sensitivity, particularly for early and familial disease, leading to many missed diagnoses in the concealed or early arrhythmic stages. The 2010 revised task force criteria represented a major improvement. They introduced quantitative imaging thresholds and refined ECG and arrhythmic definitions, which allowed for more accurate identification of earlier and familial cases while maintaining specificity. However, the diagnosis really remained RV based, which limited detection of left dominant or biventricular phenotypes. And finally, the 2020 International or the POTA criteria, depending where you see, expanded the diagnostic framework to reflect the full arrhythmogenic cardiomyopathy spectrum. This was further updated in 2023. And these criteria formally incorporated LV and biventricular phenotypes, introduced separate major and minor criteria for each ventricle, and integrated cardiac MRI, late gadolinium enhancement, updated arrhythmic criteria, and also incorporated genetic findings. This shift also improved the diagnostic accuracy and allowed recognition of non-right dominant forms of the disease, therefore moving away from the typical nomenclature of ARVC. So this is probably, this and the next slide are probably the two most important slides I have. This table summarizes the European Task Force Diagnostic Criteria from 2020. Again, this has been updated in 2023, and I'll show the kind of changes in that, but this is what a lot of the literature is citing nowadays of this specific table from 2020. So this is updated to both show RV and LV involvement, and the criteria are divided into several category, up to 6 categories with major and minor criteria. So the first category is morphofunctional ventricular abnormalities, and I'll touch on some of the major and minor for each of these. So for the RV, major criteria include regional akinesia, dyskinesia, or aneurysm, plus either global RV dilatation or systolic dysfunction according to imaging. Minor criteria include regional RV wall motion abnormalities, and for the LV, minor criteria consist of global LV systolic dysfunction with or without LV dilatation. The second category is structural myocardial abnormalities. So for major RV criteria, this involves fibrous replacement of myocardium in at least one sample, and minor criteria include unequivocal RV LGE in one region. For the LV, major criteria are ring-like subepicardial or mid-myocardial LGE in greater than or equal to 3 segments on CMR, and minor criteria involve similar LGE patterns in 1 to 2 segments of the free wall, septum, or both. The third category is ECG repolarization abnormalities. So for the RV, major criteria are T-wave inversions in right precordial leads V1 to V3 in individuals greater than or equal to 14 years old in the absence of a complete right bundle. And minor criteria involves T-wave inversions in V1 to V2. I found this interesting. It's for some reason specifically in males, which I'm not very clear why the minor criteria is male specific, but the major is not. But otherwise the criteria also involves or beyond V3 in the presence of a complete right bundle. And then for the LV, minor criteria are T-wave inversions in left precordial leads V4 to V6 in the absence of a left bundle. The fourth category is ECG depolarization and conduction abnormalities, which a lot of people associate with ARVC or the spectrum of it. So for the RV, minor criteria include epsilon waves in right precordial leads, and then also terminal activation duration, which I'll get to a little bit later. That's greater than or equal to 55 milliseconds, which is measured from the nadir of the S wave to the end of the QRS complex, including the R prime in V1 to V3 in the absence of a complete right bundle. This reflects delayed RV activation due to the fibrofatty infiltration and slowed conduction in diseased myocardium. And then for the LV, major criteria include low QRS voltages, less than 0.5 millivolts in limb leads in the absence of other causes, such as like amyloid. So this is the other 2 categories. So for the fifth category is arrhythmias. So for RV, major criteria include frequent PVCs greater than 500 per 24 hours, or non-sustained or sustained VT of left bundle morphology with a non-inferior axis. Minor criteria include frequent ventricular extrasystoles with the left bundle morphologies and inferior axis, an RVOT pattern, or a history of cardiac arrest due to VFib or sustained VT of unknown morphology. For the LV, minor criteria include frequent PVCs greater than 500 per 24 hours, or exercise-induced PVCs with a right bundle morphology or multiple right bundle morphologies excluding a fascicular pattern. Also can be a non-sustained or sustained VT with a right bundle morphology, again excluding fascicular VT and a history, or considering as well in a history of cardiac arrest due to VFib or sustained VT of unknown morphology as a minor criteria. The last category is family history and genetics. So major criteria include identification of a pathogenic arrhythmogenic cardiomyopathy gene variant in a patient, confirmation of ACM in a first-degree relative who meets diagnostic criteria, or pathologic confirmation at an autopsy or surgery in a first-degree relative. Minor criteria include a likely pathogenic ACM gene variant, a history of ACM in a first-degree relative where criteria cannot be fully determined, or a premature sudden death less than 35 years old due to suspected ACM in a first-degree relative, or ACM confirmed with diagnostic criteria in a second-degree relative. So because that was a mouthful for a lot of the different criteria that's there, I won't get into this too much, but just know that the 2023 European Task Force criteria further made adjustments, removing, adjusting, and adding certain criteria to the previous 2020 PADA or international criteria. So this figure I really liked. It outlines the characterization of phenotypic variants in arrhythmogenic cardiomyopathy or ACM. It's not foolproof flow, but it just kind of helps conceptualize what major and minor criteria you need for each condition. I think where the literature becomes a little bit ambiguous is if you this initial criteria of greater than or equal to one major or minor morphofunctional or structural RV criteria is really necessary before progressing. So like for example, if you didn't have that criteria, but you still had two other major criteria, could you make the diagnosis? According to this diagram, you can't, but according to the literature, it's ambiguous. Um, but regardless, we'll use this as an example because I think this is the most practical from what I came across. So the diagnosis is based on meeting a combination of major and minor criteria, as mentioned, involving morphofunctional, structural, or tissue characterization in the right and or left ventricular criteria. When at least one major or minor right ventricular criteria is present, the next step is to determine whether left ventricular criteria are also met. If both ventricles demonstrate abnormalities, it's biventricular ACM or bi-VACM. If only right ventricular criteria are met, then it goes into the ARVC spectrum from possible to borderline to definite, depending on the number of each major slash minor criteria. And then a diagnosis is considered definite when a patient meets two major, one major, and two minor, or four minor criteria from different diagnostic categories. Importantly, this diagram reflects also left ventricular criteria, such as non-ischemic late gadolinium enhancement on MRI, and then they term this ALVC, and also use that same sort of spectrum of possible borderline to definite. Um, Regardless of the stage, if they're at possible or borderline, the guidelines really recommend that they undergo ongoing follow-up as disease progression over time may lead them to fulfill the definite criteria diagnosis. And so I wanted to apply this algorithm just to the case that we had as an example. So first, under morphofunctional abnormalities, both ventricles are involved. The right ventricle shows regional septal dyskinesia and global RV dilatation, while the left ventricle demonstrates global systolic dysfunction with a reduced EF of 33%. This combination fulfills the major morphofunctional criteria involving both the RV and the LV. And then next in the depolarization and conduction category, the ECG demonstrated epsilon waves in V1 and V2. They're over 14 years old, and it represents delayed activation of the right ventricle, meeting another major criteria. So in total, there's two major criteria minimum here. You don't need to really look further. Applying that phenotypic algorithm from the previous slide, this would meet criteria for definite biventricular arrhythmogenic cardiomyopathy. So now to move on to the clinical side of things, ventricular arrhythmias and sudden cardiac death are a major complication, often presenting with VT with left bundle morphology for ARVC. These arrhythmias can be sustained or non-sustained and may require interventions like cardioversion or ICD implantation. Progressive RV dysfunction can lead to right heart failure. LV involvement may occur later, resulting in biventricular failure or reduced LVEF requiring GDMT, which is associated with more advanced disease and worse outcomes. Something that's not talked about as often is thromboembolic events, which can rise either due to RV aneurysms, severe chamber dilatation like LV thrombi, or atrial arrhythmias such as AFib or flutter. And these factors promote mural thrombus formation, really increasing the risk of any systemic embolism, including stroke. On ECG, epsilon waves are best seen in V1 to V3. These are small deflections after the QRS, reflecting delayed RV activation throughout diseased myocardium. T-wave inversions in V1 to V3 can be seen as the disease progresses. These inversions can extend to the inferior and lateral leads, reflecting broader myocardial involvement. Terminal activation duration is classified as greater than or equal to 55 milliseconds in V1 to V3, and I'll show an example on the next slide. Measured from the nadir, the S-wave to the end of the QRS, and is also characteristic of delayed RV conduction, as long as it's in the absence of a right bundle. And in more advanced disease, low QRS voltages can be seen in the limb leads, less than 0.5 milliseconds, and also reflect diffuse myocardial involvement. Finally, VT and ARVC typically shows like a left bundle morphology, but obviously dependent on the ventriculum that are in ventricular abnormalities that are involved. And something I also wanted to touch on that I had seen sometimes in the guidelines and seen actually used pretty inconsistently is the diagnostic utility of late potentials on signal averaged ECGs as a diagnostic modality. So this has been challenged in patients with ARVC for due to showing poor sensitivity and poor specificity. It has been noted that epsilon waves are frequently overdiagnosed, and there is poor agreement even between experts regarding their presence. Furthermore, it has been demonstrated that they occur in the presence of severe structural disease and thus usually add little to the diagnosis. Therefore, epsilon waves and SAECGs really should be used for diagnostic purposes with caution. So here are just some examples of epsilon waves. You can see on the left here where the arrows are pointing to see the epsilon waves are most prominent in V1 and V2 typically. And then on the right-hand side, you can see there's an example of terminal activation duration and how it's measured. Something else I also wanted to touch on in the guidelines was the use of Fontaine bipolar precordial leads. And they actually do have stronger recommendations for this as opposed to signal average ECGs. So Fontaine leads increase the sensitivity of epsilon wave detection, which can sometimes be subtle on standard ECG leads. The lead placement is different from the usual precordial configuration. So the right arm electrode is placed over the manubrium, the left arm over the xiphoid process, and the left leg in the standard V4 position at the fifth intercostal space in the mid-clavicular line. Instead of the standard limb leads 1, 2, and 3, this setup produces called the three bipolar chest leads F1, F2, and F3, which record potentials generated in the RV from the infundibulum to the diaphragm. The F1 lead, which is vertical and similar to AVF, magnifies atrial potentials. This makes it especially useful for detecting epsilon waves, searching for AV dissociation during VT, and studying abnormal atrial rhythms when P waves are too small on standard leads. So here's just an example of an epsilon wave becoming more prominent once Fontaine bipolar precordial leads are used, which you can see it looks very difficult to assess in a standard ECG, but with the FECGs, it looks much more prominent. When we look at echo findings in ARVC, the earliest change is usually regional RV dilatation, which is why they really emphasize regionality as a primary abnormality to look at in diagnosis. Most often involving the triangle of dysplasia that I had mentioned earlier, involving the inflow tract, RVOT, and apex of the RV. And then we can see regional wall motion abnormalities as well, like akinesia or dyskinesia, and sometimes aneurysm formation in these segments. With disease progression, this regional dysfunction can evolve into global RV systolic dysfunction. LV size and function are typically preserved early, but can become more evident with time with dysfunction. And RV dilatation progresses, functional TR often develops, and this can also contribute to right heart failure. MRI plays a central role in evaluating ARVC, particularly for tissue characterization and structural assessment. So it can detect fatty infiltration in the RV and occasionally in the LV. Cardiac MRI identifies RV dilatation, aneurysm formation, and wall motion abnormalities such as dyskinesia. One distinctive feature is something called the accordion sign, which is corroborated or rippled appearance of the RV-free wall caused by localized dyskinesia and wall thinning. It can also detect focal LV dyskinesia, especially when LV fatty infiltration is present. Finally, cardiac MRI is highly effective for detecting myocardial fibrosis and scarring with delayed enhancement, and it provides accurate quantification of the LVEF and, more importantly, on cardiac MRI, the RVEF, which is much more limited on echo. I also wanted to touch on the role of EMB and nuclear scans in the context of ARVC or the spectrum of ACM. So endomyocardial biopsy helps differentiate ARVC from inflammatory conditions like myocarditis and sarcoid, especially in sporadic cases or where non-invasive tests are inconclusive. What can help is electroanatomic voltage mapping guided biopsy targets, as the areas of low voltage identified during this mapping increases the diagnostic yield and reduces sampling error, which is particularly helpful in cardiac MRIs that appear negative. With regards to nuclear imaging, 18F FDG PET can support the diagnosis of, as we know, cardiac sarcoid when there is a focal or focal on diffuse uptake pattern. However, ARVC can also show myocardial FDG uptake, so it is not very specific. Radionucleotide ultimately in the guidelines plays a limited role in ARVC and is mainly used if there's abnormal extracardiac FDG uptake or clinical features suggesting sarcoid on the differential. The guidelines also touch on genetic screening. So the majority of pathogenic variants in ARVC occur in genes encoding desmosomal proteins, which form the intracellular junctions anchoring cardiomyocytes. These structures provide critical mechanical coupling, allowing the myocardium to tolerate repetitive contractile stress, which I found this interesting because that's why ARVC is hypothesized progression is suspected to worsen with high intensity exercise. Disruption of desmosomal integrity leads to myocyte detachment, apoptosis, and subsequent fibrofatty replacement, which really underpins the pathogenesis, structural, and arrhythmogenic phenotype of ARVC. Beyond desmosomal genes, pathogenic and likely pathogenic variants have been identified in non-desmosomal proteins, and broadening the molecular, this just broadens the molecular spectrum of ARVC and really highlights the heterogeneity of the disease person to person. Pathogenic or likely pathogenic variants can be detected in up to 60% of those clinically diagnosed cases, underscoring the importance of genetic testing in both diagnosis and cascade family screening. The inheritance pattern is typically autosomal dominant, but penetrance is really variable and vastly influenced by age, sex, and exercise exposure, with early and more severe phenotypic expression in younger males engaged in high intensity activity. Genetic variants required periodic reappraisal given evolving classification standards and new population level data that may reclassify variants over time. So even if the variant that they have is equivocal or not necessarily in contribution with ARVC, oftentimes because this is really evolving rapidly, if this is reevaluated several years later, that patient who was maybe borderline for ARVC may now be definite ARVC, depending on the current literature at that time. And for first degree relatives, longitudinal surveillance is recommended every 1 to 2 years, incorporating ECG, echo, Holter monitoring, and baseline cardiac MRI to detect any early electrical or structural manifestations prior to overt disease expression, given the risk of sudden cardiac death. So now to touch on the current evidence, which is honestly not great, but understandably limited given the low population of ARVC and how niche, especially a lot of the phenotypes are. So most of the current evidence on the outcomes of patients with ARVC and the predictors is limited to observational retrospective cohort studies that are typically of small size. The number of clinical predictors that can be studied using multivariate models is very limited, and most studies cannot be compared with one another, even when available. A systematic review and meta-analysis of 18 studies, for example, has shown that the average risk of ventricular arrhythmia ranges anywhere from 3.7 to 10.6% per year. But the literature shows that male sex, RV dysfunction, and prior even non-sustained VT or sustained VT-VF consistently predicts ventricular arrhythmias in populations with ARVC. And the European Society of Cardiology highlights several key gaps in evidence for ARVC. So there is a lack of randomized control trials evaluating therapies for the management of arrhythmias and heart failure, limiting the strength of treatment recommendations. Studies examining the impact of exercise are largely retrospective, which restricts the ability to draw causal inferences. And data on the incidence and prognostication of heart failure and ARVC really remains limited. We extrapolate, obviously, the GDMT data and hindering accurate risk stratification and long-term planning. Additionally, there is lack of evidence regarding the optimal frequency and mode of clinical screening for asymptomatic family members, leaving a lot of the current screening strategies to be largely based on expert consensus rather than high quality data. So to start here, most commonly that people do annual ambulatory ECG monitoring carries a class 1 recommendation in the 2023 ESC guidelines for patients with ARVC. It's really strongly recommended to support diagnosis, management, and risk stratification. And then before I get to the guidelines, just to touch generally on management, clinical management aims to improve symptoms, slow disease progression, and prevent complications. Beta blockers are the first line therapy to reduce arrhythmic burden by lowering adrenergic tone, particularly during exercise. The goal is to titrate to the maximal tolerated dose, which has been associated with improved survival from major ventricular arrhythmias in retrospective studies. If beta blockers are insufficient, amiodarone is often used as the next option. However, it should be used cautiously for long-term therapy, especially in younger populations due to potential toxicity. Sotalol has also been mentioned in the guidelines and has historically been used, but the evidence for its efficacy really remains limited and somewhat conflicting. Flecainide has more stronger recommendations and can be considered when monotherapy isn't enough to control symptoms or if beta blockers are not tolerated due to autonomic side effects. For some patients, medical therapy alone isn't sufficient, and that's when these individuals may require ICD implantation and/or invasive arrhythmia procedures. This can include endocardial or epicardial ablation guided by 3D mapping. However, recurrence rates remain high, even up to 30 to 50% in experienced centers. Sympathetic denervation can also be considered in select cases. While these interventions don't fully protect against sudden cardiac death, they can significantly reduce VT burden and the risk of a VT storm. And finally, discontinuation of intense physical exercise has been shown to help slow disease progression and reduce ventricular arrhythmia burden, so lifestyle modification is also key. So here, in terms of the class of recommendations for ARVC, patients with ventricular ectopy, non-sustained VT, or VT, beta blockers are recommended as first-line therapies with a class 1 recommendation. Amio and flecainide both have a class 2A recommendation, and catheter ablation also has a class 2A recommendation as well. This includes epicardial approaches guided by 3D mapping. It should be considered for patients with incessant VT or frequent appropriate ICD interventions despite optimized medical therapy. An ablation can reduce VT burden and ICD shocks, but again, as mentioned, the recurrence rates remain high even in experienced centers, so it's typically used as an adjunct therapy rather than curative. You'll note that also sotalol is not on here due to conflicting and limited evidence. For secondary prevention of sudden cardiac death, ICDs have been shown to reduce mortalities in survivors of cardiac arrest and in patients who have experienced sustained symptomatic VT. An ICD is recommended in these patients where the intent is to increase survival, but the decision to implant with a lot of these sort of situations should be taken into account with the patient's perspective, their quality of life, and the absence of other comorbidities that are likely to cause death within the next year, as per the guidelines. So for primary prevention ICD in ARVC, most of the evidence we currently have is based on small retrospective observational cohorts. The 2015 International Task Force Consensus was the first to propose a structured risk stratification framework for ICD decision making based on the presence of clinical risk factors. A follow-up study of 365 patients refined this framework and improved risk discrimination. And then subsequently, a multi-center risk prediction model involving 528 patients was developed, and this model uses factors such as sex, age, recent syncope, non-sustained VT, ventricular ectopy count, and the number of T-wave inversions and RVEF to provide an individualized risk estimate of sustained VT in ARVC patients. And this tool is actually available at a website called arvcrisk.com that I've put on the slide here. And then when it comes to primary prevention ICDs, universal thresholds for acceptable risk are difficult to define across ARVC phenotypes. Ultimately, the guidelines and the task force recommends a similar approach to what's used for hypertrophic cardiomyopathy and/or dilated cardiomyopathy with an emphasis on shared decision making. Sustained VTs in ARVC can often be well tolerated, so using appropriate ICD therapies as a surrogate for sudden cardiac death risk can actually overestimate the true risk. And many patients with ARVC end up receiving ICDs regardless, which complicates efforts to accurately really risk stratify sudden cardiac death risk. Several studies have tried to refine risk by focusing on fast VT over, usually defined by over 250 beats per minute, rather than an all sustained VT across the board. A risk score for unstable VT or VF was developed in a cohort of 864 patients, but external validation is lacking and specific rate cutoffs aren't evidence-based. So, and what further complicate things is slower VTs are likely less life-threatening, but we don't really know how often these slower arrhythmias progress to faster VTs or VF. So for that reason, it's overall considered reasonable to offer primary prevention ICDs to all patients at risk of sustained ventricular arrhythmias in ARVC. For secondary prevention, ICD implantation is a strongly recommended for patients with ARVC who survived a cardiac arrest or recovered from a ventricular arrhythmia causing hemodynamic instability. This is a class 1 recommendation. An ICD should be considered for patients who have experienced hemodynamically tolerated VT, which is a class 2A recommendation. For primary prevention, the decision is based on risk stratification. So I found this very helpful. The guidelines outline high risk features such as arrhythmic syncope, even non-sustained VT, reduced RVEF below 40%, reduced LVEF below 45%, or sustained monomorphic VT during programmed electrical stimulation like a VTEP study. Uh, should gu- uh, uh, this should guide individualized decision making, and this carries a Class 2A recommendation as well. The updated 2019 ARVC risk calculator can also be used to support ICD decision making in the guidelines, again with a Class 2A recommendation. The algorithm on the right summarizes this visually, which I really like. If a patient has had a cardiac arrest or syncopal VT, ICD is indicated, class 1 recommendation. If the patient has had a non-syncopal sustained VT, an ICD is considered class 2A. And if they have high-risk features, as mentioned previously, without prior VT, an ICD is again considered a class 2A recommendation. So, in summary, to end off, ARVC is a genetically determined cardiomyopathy characterized by fibrofatty replacement of the RV myocardium, which predisposes ventricular arrhythmias, progressive dysfunction, and sudden cardiac death. Diagnosis integrates ECG, imaging, EMB, and genetic testing guided by the 2023 ESC criteria, which seem to be the most latest guidelines. And management focuses on arrhythmia control, prevention of sudden cardiac death, slowing disease progression, especially with exercise counseling and shared decision making for ICD implantation. And ultimately, there's significant evidence gaps with limited prospective data and no randomized control trials, which emphasizes the need for individualized care and careful risk stratification. There is a randomized control trial, I believe, that's currently underway in the States, looking at flecainide in ARVC. They've only published an abstract, so there's really not much data to really get into. But time will tell eventually once this comes out, what's the utility of flecainide that's currently at a 2A recommendation. Ultimately, early recognition, structural follow-up, and multidisciplinary management are really key to improving outcomes. These are the references that I use in the guidelines I cited. Thank you everybody for listening to my talk.